This is part E in the Practical Transfusion Medicine series for internal medicine residents rotating through their hematology ward and consult rotations at the University of Alberta Hospital in Edmonton, Alberta. This is Dr. Wong. So just to get back into the vitamin K cycle and how warfarin affects the coagulation factors, just to recap, your liver makes precursors to your 2, 7, 9, and 10, and in order for them to participate in the coagulation cascade, these precursors must be carboxylated, and this reaction ends up oxidizing vitamin K into its epoxide form. And then in order for vitamin K epoxide to be reduced back into its hydroquinone form to keep making the carboxylated 2, 7, 9, and 10 for the coagulation cascade, the epoxide form must first be reduced by vitamin K epoxide reductase. This is the enzyme that is warfarin sensitive. This generates vitamin K quinone. This is also the form of vitamin K that is available as the pharmaceutical agent, PO or IV, as well as the source of vitamin K in food sources. So the quinone vitamin K undergoes a final reduction step by vitamin K reductase back to its hydroquinone form to continue the carboxylation reaction. Vitamin K reductase is not warfarin sensitive. So when the patient is anticoagulated on warfarin, K epoxide is stuck as K epoxide, and in order to override the warfarin inhibition step, vitamin K can be supplied in the food sources or as the IV or PO agent for vitamin K reductase to work on to convert it to the hydroquinone form, or you can actually supply the patient with the factors 2, 7, 9, and 10, which is in plasma as well as in prothrombin complex concentrates. Again, oral vitamin K takes 18 to 24 hours for effect. IV vitamin K takes 6 to 12 hours for effect. So if your patient is anticoagulated on warfarin or has vitamin K deficiency and experiences a life-threatening bleeding episode or requires emergency surgical intervention within 6 hours time frame, your vitamin K is not going to be useful as a solo agent to reverse the warfarin. So we were talking about how you can directly provide the factors 2, 7, 9, and 10 to bypass the warfarin effect. So you can do that by transfusing plasma, or you can give prothrombin complex concentrate. Plasma would require a Tiedemann screen, which of course will take 30 minutes. Plasma, because it is stored frozen, just as we mentioned before, it will take another 15 minutes to thaw before it can be issued out the door. So already you're adding on 45 minutes to the waiting time before the product can even start to have an effect on the patient who is having a severe life-threatening bleeding or requiring emergency surgery within 6 hours when anticoagulated on warfarin. So for those two scenarios specifically, PCC is now the product of choice and is the standard of care. So what is in prothrombin complex concentrate, and we'll use Octaplex as the example. So it has factors 2, 7, 9, 10, proteins C and S, and if we are talking about Beriplex, which comes from another company, the only difference is that Beriplex also has some antithrombin in it as well. Regardless of whether you're dealing with Octaplex or Beriplex, PCC will have some heparin in it, and that becomes a major concern if your patient has ever had heparin-induced thrombocytopenia. An average 40 cc dose is going to be $620 Canadian, as per the Canadian Blood Services billing information. And each box of Octaplex will have 2 vials in it. One vial is the lyophilized powder for reconstitution. The other vial is the sterile water for injection. To actually receive PCC, whether Octaplex or Beriplex in the Edmonton zone, you must fill out the PCC request form, which is available on the Edmonton zone Transfusion Medicine website, and we will go through that a little bit later. The most important information to fill in, of course, is the patient demographics, as well as the requesting physician's information. Dosing is based as per the baseline INR, and we will look at that in the next slide. And more importantly, remember to look on your Netcare electronic medical record under the coagulation folder to see if your patient has ever been tested for heparin-induced thrombocytopenia, and if so, click on the test to actually read the result. HIT is an absolute contraindication to receiving PCC. After that form is filled in, then you fax it to the blood bank where your patient is located to receive the product. PCC, the dosing is INR dependent, so to be eligible for the PCC, the baseline INR has to be at least 1.5. And if the INR is 1.5 to 2.9, the standard dose is 2 vials or 40 cc's. If the INR is 3 to 5 or unknown, then we give 80 cc's. The maximum dose given is 120 cc's, or if the INR is already greater than 5. Regardless of what the baseline INR is, if you give the proper dose of PCC, it should reverse the warfarin anticoagulation by lowering the INR. PCC, once infused, the effect lasts only 6 hours. Hence, that is why there's the caveat of the 6-hour time window for the surgical intervention that your patient requires. To administer PCC, the vial of freeze-dried powder is reconstituted with the sterile water, which is the other vial included in the package, and the entire liquid mixture is infused at 3 cc's a minute. So depending on the dose, 40 to 120 cc's, the time to infuse will be 12 to 40 minutes in total. Because PCC lasts only 6 hours, if a prolonged reversal is required beyond the 6-hour time frame, we also recommend giving vitamin K IV concomitantly. To see whether the PCC actually is effective in lowering the INR should be repeated 10 to 30 minutes after the PCC is done infusing. PCC as a product is prothrombogenic, just like FEBA and recombinant 7A that we mentioned at the beginning of Part A. Various side effects are associated for the prothrombogenic effect of the product, going anywhere from superficial thrombophlebitis to DVT-PE, arterial thrombosis, and DIC. So this is a product that is not without risk and should be used appropriately and with caution. Because PCC only has the vitamin K dependent factors, so 2, 7, 9, 10 protein CNS, and for Beriplex also some antithrombin, PCC is not recommended if you are missing multiple coagulation factors. So in the setting of coagulopathy of liver disease, disseminated intravascular coagulopathy, massive transfusion, or the reversal of non-vitamin K anticoagulants. If the INR is elevated on warfarin, but the patient is not bleeding, nor does he or she need a surgical intervention, there is no point in treating the number. PCC is prothrombogenic, so use with caution if your patient has had a recent history of MI or thrombosis. And remember, PCC is a plasma-derived product and it is not recombinant, so it is important to discuss this with your patient if he or she happens to be a Jehovah's Witness. I was mentioning that PCC versus plasma, there are various differences. Most importantly, in terms of reversing it in an emergency setting, Octoplex or PCC is now the preferred product because it does not require tightened screen, it does not require thawing of the product before issue, and it can, because of the small volume used, the average dose of 40 to 120 cc's, it is more rapidly given than plasma. We already mentioned that for other coagulopathies such as liver disease and DIC, in which there's a global factor deficiency, not just the vitamin K dependent factors, PCC is not the appropriate product to use, and PCC is neither recombinant nor should it be used as a plasma substitute. So take-home points: use PCC only for the emergency reversal of warfarin and vitamin K deficiency. And for the reversal of warfarin and vitamin K deficiency in non-emergency situations, I'll refer you to the CHEST 2012 guidelines, as well as the American Society of Hematology 2011 guidelines available on the web. finally, there are some very useful resources that you may use during your rotation and beyond available in the Edmonton zone. This website refers to the Alberta Health Services Transfusion Medicine website, so if you put it in your search criteria, you will end up at this site where you will find information regarding blood components and products information, any product that we have in the region, as well as if you click on this link, it will lead you to the IVIG request forms and the PCC request forms that you need to fill in to get the product. A couple of other resources that are very helpful. This is a guide to transfusion medicine put out by the Transfusion Ontario Society. It's available as a free downloadable PDF, and it's called Bloody Easy 3. And this group has also recently come up with a Bloody Easy Coagulation Simplified Guide, also available on www.transfusionontario.org. And finally, your local resources are often best, so your hematopathologists also who do transfusion medicine call are Dr. Susan Naherniak, Dr. Graham Clark. Dr. Naherniak and Dr. Clark are the transfusion medicine co-directors for the Edmonton zone. Dr. O'Neill works primarily at the Misericordia Hospital, but he is also on the transfusion medicine schedule. Dr. Skotek and I are the fillers for the TM schedule when there is an empty spot, but we are primarily no longer on TM call. And of course, Dr. Lauren Bolster, who you know from your rotations, and she is also available as a valuable blood bank transfusion medicine resource person in the region. Thank you for listening.